Good morning everybody. I'm Dr. Sanjana. I'm a final year resident from MVJ Medical College and today I will be presenting a case. Mr. Rabish, aged 42 years, educated till 7th standard, who is working as an electrician but currently unemployed. Kannada speaking, married Hindu male living in a nuclear family of lower middle socioeconomic status, hailing from Hoskote, a rural background where the nominal and functional head of the family being the patient himself, was brought to the psychiatry OPD by his brother and sister-in-law with chief complaints of talking to self and suspiciousness since 1 month. According to patient, hearing of voices, feeling that somebody has inserted a speaker into his head since 1 month. Informants being the patient himself, his brother and sister-in-law. Information is reliable and adequate. The onset of the illness is insidious. The course is continuous and progressive and no stressors could be elicited. History of presenting illness. Patient was apparently normal till 1 month ago when patient's uncle, who lives opposite to his house, had installed a CCTV camera for his security purposes. Following this, patient reports that he started to develop a suspiciousness that 7 to 8 people who live in that house, including his uncle and a few of his friends, have installed CCTV cameras all over the place to track his every move. He says that all of his activities and movements are being recorded to collect evidence to kill him and his family. Following this, patient would go to the uncle's house at odd hours to pick up fights and slur abusive words at them, would go to his house at night and throw stones in their windows, asking why he's torturing them and what wrong he has done to his uncle. Patient reports that soon after, one day during his sleep, some people have managed to fit speakers into his head through which he can hear the voices of multiple people. He reports he can hear the voice of 7 to 8 known and unknown voices, males and females, that are talking directly to him, and the patient can also talk back to those voices through the speakers. On questioning who installed the speakers and why the speakers were fit into his head, patient reports in his verbatim translated into English saying, there is this one guy, he's the one who's doing everything, he tortures me, he's the reason for my struggle, I cannot tell you his name. He reported that through the speaker, somebody who he doesn't want to name is being able to listen to all of his conversations and is also currently listening to the answers he gives to the examiner who is interviewing him. Patient took a pause of about 5 to 10 seconds during this point at the interview and uttered a few foul words looking at the ceiling. On asking who he was talking to, he reported that his friend, who he still did not want to name, is talking to him from the ceiling and scolding him for being alive. Patient reports that sometimes he can also hear these voices coming from his village, which is over 30 kilometers away from the hospital. The voices are intermittently heard and are always abusive towards him, talking among themselves and also directly to the patient. The voices threaten to kill the patient and himself or command him to go die. Patient reports that he doesn't feel fearful on hearing these voices but instead feels angry. As patient says, he loves his family a lot and will not tolerate anybody talking ill about his family. He reports that the voices have of late turned off the speaker in his head, but still they're able to talk to him and getting to know his deepest thoughts. On asking how this is possible, he says he doesn't know, but it happens and I will not be able to understand his suffering. He reports whatever thoughts he gets, he feels like the 7 to 8 people who have installed the cameras are getting to know him, and because of which they're able to get his weakness and collecting more evidence to kill him. On questioning the attenders how patient would respond to the voices he hears, they report that sometimes he would be noticed to be scolding the voices, threatening the voices loudly, or sometimes he would be seen squatting in a corner, covering his mouth with his hands, muttering something to himself, and also performing gestures like nodding and punching. He reports that since the last 20 days, the torture caused by these individuals whose voices he hears has increased, as now they are able to control his abdomen from the outside. He reports that he does not know how, but at certain times of the day, he feels like his abdomen is being twisted from the outside and the abdomen is also being spontaneously distended and shrunk at the same time, because of which he is not able to eat and there is significant loss of appetite. Patient also reports that he has difficulty in sleep initiation, where he takes more than 1 to 2 hours to fall asleep because the hearing of the voices are at maximum during the time that he goes to sleep, where the voices are constantly talking ill about him. and threatening to kill him. But however, once patient falls asleep, he sleeps without any difficulties and feels relatively fresh the next day morning. For such complaints, he was brought to MVJ Medical College for further management. There is no history of seeing of images that are not perceived by others, no history of thought insertion or thought withdrawal, no history of pervasive sadness of mood, crying spells, reduced interest, easy fatigability, no history of elated mood, overspending, overtalking, over-religiosity, talking high of self, no history of feeling of impending doom, constant nervousness, no history of repeated intrusive thoughts or acts, no history of head injury, seizure disorder or substance use. Past history: patient was electrocuted over 2 years ago while he was working, for which he was admitted in a hospital for over 20 days. However, details of the same are not available. There is no history of type 2 diabetes mellitus, hypertension, asthma, epilepsy or other neuropsychiatric illness in the past. Family history: patient is third in birth order out of 4 siblings, born to a non-consanguineously married couple. There is history of neuropsychiatric illness in the family, where 2 of his sons have been diagnosed as a case of autism spectrum disorder and have congenital deafness and muteness. The knowledge of the illness among the family members is poor, but however, concern for the patient's health is present. Personal history: details of birth and early development could not be collected due to the lack of a reliable attender. Behavior during childhood: according to brother, there was no thumb sucking, nail biting, temper tantrums, bedwetting, stammering or other features of conduct disorder in the form of frequent fights, truancy, stealing, lying or gang activities. He used to have congenial relationships with parents, siblings and peers. There was no history of repeated physical illness in childhood. Schooling: the patient has studied till 7th standard. It was state board Kannada medium. He was average in studies but quit following the demise of his father due to age related causes. After which, due to poverty, he started working to contribute to his family income. There was no history of disciplinary actions against the peers or the authorities. Schooling: patient quit school and joined as an assistant to an electrician and later learned the job by himself and became an independent electrician. He reports he was very satisfied with his job as he used to earn about 350 to 500 rupees per day, however not working since the last 25 days. Sexual history: he denies history of sexual exposure during adolescence. Patient reports that his sex life used to be satisfactory and not willing to currently discuss about it further. Patient's wife was not present at the time of interview to enquire the same. Marital history: patient was 23 years at the time of marriage. His wife was 20 years. It was an arranged marriage with consent of both the couple as well as the family members. Patient reports that the relationship between the couple is congenial with equal role allocation and sharing of responsibilities. The couple have 2 sons aged 11 years and 9 years. Premorbid personality: social relations: patient used to be attached to his friends more than family, was a follower among work and workmates, was ambitious and adjustable at work. Mood: he was predominantly bright and cheerful, was an active individual who was calm and relaxed, optimistic with stable mood and was able to show emotions of sadness, happiness and anger. Character: attitude towards work and responsibility: he used to welcome responsibility, made decisions easily, was methodical in approach and flexible. Interpersonal relationships: he was confident, not sensitive to criticism, trusting of others, emotionally controlled, outspoken, enjoys the company of others and tolerant of others, and was moderately religious with no fantasy thinking. Thereby I'd like to infer that he was pre-morbidly well adjusted. General physical examination: patient is moderately kempt and groomed, has multiple erythematous eruptions over the face, especially below the eyes and the cheek area. Multiple well circumscribed warty lesions present over the dorsum of the hands, measuring about 0.5 centimeters in diameters. There is pallor present. Vitals are within normal limits. BMI is 17.5, which is suggestive of underweight. Systemic examination: CVS examination: there is a linear irregular scar measuring about 10 to 3 centimeters present over the front of sternum. S1, S2 heard, no murmurs. Respiratory system: bilateral normal vesicular breath sounds heard, no added sounds. Per abdomen system is soft, non-tender and bowel sounds are present, no organomegaly. CNS system: the cranial nerve examination: first cranial nerve is intact bilaterally. Second cranial nerve was checked for visual field, visual acuity, color vision, which is intact bilaterally, and the direct and the indirect reflex was intact bilaterally. The third, fourth and sixth cranial nerve: bilateral pupils are round, regular, reactive. Accommodation reflex is present bilaterally, no nystagmus, extraocular movements are normal, no ptosis or meiosis. The fifth nerve, both sensory and motor components intact bilaterally. 7th cranial nerve, sensory and motor components intact bilaterally. 8th cranial nerve, René's test, bilateral, there is air conduction more than bone conduction, and Weber's test is centralized. The 9th and 10th cranial nerve, gag reflex is intact, palate is normal bilaterally, uvula is central with no deviation. For the 11th nerve, the sternocleidomastoid muscle and the trapezius muscle was checked, which was intact bilaterally. For the 12th cranial nerve, the shape, size, surface of tongue was normal, no wasting of fasciculations or other abnormal involuntary movements of the tongue noticed. Motor system examination, the power is normal bilaterally, where bilateral upper limbs and lower limbs was 5/5, tone is normal, bulk, attitude was normal, no wasting or abnormal involuntary movements noticed. Reflexes, superficial reflex, plantar reflex, bilateral flexion response was seen, and deep tendon reflexes, the biceps, triceps, knee jerk, supinator, ankle jerk was 2+ bilaterally. Sensory system examination, touch, pain, temperature, joint position, vibration sense, intact bilaterally. Cortical sensation, stereognosis, tactile discrimination, tactile localization, graphesthesia, intact bilaterally. Test for coordination, there was no dystidokinesia. Finger nose test, patient was able to do. He was able to perform knee heel test. Romberg sign was negative. He was able to perform tandem walking and no nystagmus. By this, I'd like to infer that there was no focal neurological deficits. MSc was done on the 17th of September 2024 between 5:30 p.m. to 6:30 p.m. where the language of interview was Kannada. Patient walked into the duty doctor's room and sat on the chair following reassurance. Attitude towards the examiner initially was guarded but later became cooperative. Manner of relating was relaxed. There was no abnormal involuntary movements, mannerisms, posturings or other catatonic features. Hallucinatory behavior was noticed during the interview. Eye-to-eye contact was established but not maintained. Rapport was established with difficulty. Psychomotor activity was normal. Cognitive status examination, for attention and concentration, he was asked to do serial subtraction of 100 - 7, which he was not able to do, 40 - 3, which he was not able to do, but 20 - 1 he was able to do, and was also able to say the days of the week forward and backward. Thereby, I'd like to infer that his attention is arousable and concentration is well sustained. For memory, for immediate memory, he was given the 3-object test of car, ball, house, which was immediately able to recollect. And for recent memory, he was asked to recollect the 3-object test within 5 minutes, which was able to do. And the events of the last 24 hours were recalled, like his mode of transportation to this hospital, the meals that he had the previous day, which was corroborated with the attendant. Therefore, his recent memory is intact. For remote memory, he was asked about the age of his children, his marriage year, and his birth date, which was corroborated with the attender present. Therefore, I would like to infer that his remote memory is also intact. For intelligence, for general fund of information, he was asked to name the PM of the country, the CM of the state, the reason for wearing mask a few years ago, and also for calculations, he was given simple arithmetic calculation and word format problem, which was able to do. Thereby, I'd like to infer that his intelligence is average. For thinking, he was asked if he knew any proverb, for which he said he did not know. Later, he was given the example of 2 simple and common Kannada proverbs, which he was able to give the appropriate explanation of. Therefore, I'd like to infer that his thinking is at abstract level. For judgment, for test judgment, he was given the fire test. He said he would douse it out with water and call the fire brigade. For personal judgment, I would like to infer that it is intact, as patient reports he wants to get better, he wants to go home and wants to look after his family. Social judgment, I would like to infer that it is impaired because patient is seen to be making abusive slurs towards his relatives, goes, picks fights in the middle of the night, and also seen having hallucinatory behavior. Speech is relevant and coherent with normal tone, tempo, volume, normal reaction time, normal rate and rhythm with normal intensity. Thought, for stream, his thought is generated at moderate pace, no accelerations or decelerations, no flight of idea, circumstantiality, thought block or perseveration. For form, a neutral topic of Diwali was given. He spoke as well as wrote appropriately on the topic. By this, I was not able to infer the presence of any loosening of association, derailment, omission, substitution, neologism, or other components of formal thought disorder. For content, patient reports that there are 7 to 8 people, some of whom are his friends, who are torturing him by various means and want to kill him and his family. And every move of his is being watched by cameras that have been inserted inserted to follow him. Thereby, I'd like to infer that patient has delusion of persecution, which is a primary delusion. The affect associated with it is irritable, which is a non-bizarre type of delusion, for which he has strong conviction, has significant acting out behavior extending into his other aspects of life. Patient also reports that there is an outside source which is twisting his internal organs, especially his intestine, because of which there is spontaneous bloating and shrinkage of his abdomen, because of which he feels like his appetite is reduced. Thereby, I'd like to infer that patient has somatic passivity. Patient also reports that there is a camera that is inserted into his head. How, he does not know, but reports that through this, all of his deepest thoughts and his secrets are being known to others, especially his persecutors, because of which they are able to find out his weakness, which they ultimately going to use to kill him. Thereby, I'd like to infer that patient has thought broadcast. Possession. No other forms of possession disorder like obsessions or compulsions are present. Mood, subjectively he says he's not good. Affect is restricted, which is congruent to his thought, appropriate to situation, has restricted range and reactivity, no lability, and non-communicable. Perception, patient reports of being able to hear multiple verbal, intermittent voices, about 7 to 8 in number, which are familiar and non-familiar, telling him unpleasant things which are abusive in nature, coming from a distance of over 30 kilometers. These voices are talking to themselves and also talking to the patient. Thereby, I'd like to infer patient has second person extracampine type of auditory hallucinations as well as third person auditory hallucinations. Insight is 0 out of 5 where patient denies the presence of any kind of psychiatric illness. Summary, Mr. Ravish, aged 42 years, Kannada speaking, married Hindu, educated till 7th standard, currently not going to work since the last 20 to 30 days. Earlier was an electrician, living in a nuclear family, hailing from Hoskote of rural background, was brought to the hospital with chief complaints of talking to self and suspiciousness since the last 1 month, and according to patient, hearing of voices, feeling of speaker being attached to him since the last 1 month. The patient reports that there are 7 to 8 people who have inserted cameras to follow him and watch his movement, inserted speakers into head to hear his thoughts and to hear his conversations, and who also speak to him. He reports he hears 7 to 8 voices of males and females, all familiar voices coming from over 30 kilometers away. Voices are intermittent, abusive type, always telling him to die or threatening to kill him and his family. Patient reports that somebody is controlling his internal organs from outside, which is causing it to get twisted and causing simultaneous bloating and shrinkage of his abdomen, with significant social and biological impairment, with the significant past history of being electrocuted over 2 years ago, requiring hospital admission for over 20 days, with significant family history of autism spectrum disorder in both his sons and congenital deafness and muteness in both his sons, with nil significant personal history and pre-morbidly well-adjusted personality. On examination, he is moderately built and nourished with multiple erythematous eruptions over his face and body lesions over his hand. Pallor is present. Systemic examination within normal limits. MSc, psychomotor activity is normal. Speech is relevant and coherent. Thought, he has delusion of persecution, somatic passivity, and thought broadcast. Mood, subjectively he says he's not fine. Affect is restricted with second person extracampine auditory hallucinations and third person auditory hallucinations. On cognitive status examination, he is conscious and oriented to time, place, and person, has arousable attention and sustained concentration, intact memory functions, average intelligence, has abstract level of thinking, with impaired social judgment and insight of 1/6. Diagnostic formulation, Mr. Ravish, 42-year-old male, currently unemployed, hailing from rural background, with significant past history of being electrocuted 2 years ago, with hospital admission for over 20 days, significant family history of autism spectrum disorder and congenital deafness and muteness in both sons, with nil significant personal history and pre-morbidly well-adjusted personality. Was brought to the OPD with chief complaints of suspiciousness, talking to self since 1 month, and according to patient, feeling of internal organs being twisted, with significant acting out behavior in the form of blurting out abusive slurs and muttering to self, with significant impairment of biological and social impairment. On examination, there are warty lesions present over the dorsum of hands, erythematous rashes over the face, BMI is underweight, thought delusion of persecution, thought broadcast, and somatic passivity present. Affect is restricted with second person and third person extracampine type of auditory hallucinations. Cognitive status examination with the normal limits, except for impaired social judgment with an insight of 0 by 5. By this, I would like to give a provisional diagnosis under axis 1 as paranoid schizophrenia F20.0, under axis 2 well-adjusted personality, and under axis 3 there is verruca vulgaris, there is rosacea, and also underweight and anemia under evaluation. Sorry, for management, I would like to manage this patient under locus, focus, and modus. Locus, I would like to admit the patient under IP care. The reason being there is significant acting out behavior present. Focus, I would like to focus on his frank positive symptoms and would also like to look into the psychoeducation of his family members and treatment of other medical conditions that he currently complains of. Modus, I would like to start the management by doing basic investigations like CBC here, because the patient, since he is anemic, would like to know the hemoglobin level and the RBC count in this patient. Would also like to do RFT and LFT to ascertain his baseline levels of his metabolism, because antipsychotics, they get metabolized through the liver and the kidney. And also ECG and serum electrolytes. I would like to do neuroimaging like MRI brain in this person. I would also like to apply a psychometric assessment, for example scales like Panis scale and BPRS scale, to ascertain his baseline score, and I would like to repeat it at frequency of 3 to 4 days to ascertain if there is any improvement in his symptoms and to follow his prognosis. Later, coming to the use of pharmaceutical agents, I would like to start with a second generation antipsychotic, preferably olanzapine. Considering his underweight status also, olanzapine would be a good choice. I would like to start at 5 milligram and slowly increase the dosage to 20 milligram, which is the maximum dose, over a period of 4 to 6 weeks while I am observing the improvement that is seen in the patient. At the same time, I will also watch for any side effects like extrapyramidal symptoms. If at all the patient with the adequate dose and the adequate duration, if he does not show significant improvement with this drug, I would like to cross titrate with another second generation antipsychotic, preferably risperidone, starting at a dose of 2 mg, hiking up till 8 mg over a period of 4 to 6 weeks, watching for improvement. If despite the use of second generation antipsychotics there is no significant improvement, I would like to augment him with the first generation antipsychotic like haloperidol, starting from 2.5 mg going up till 20 mg. But this time I would also like to be careful about the EPS that can occur in the patient, considering his low body weight, considering the use of two high potent antipsychotics. And even after adequate duration and even after using two different classes of antipsychotics, if there is no significant improvement on objective as well as subjective assessment, I would like to consider him as treatment resistant schizophrenia and start him with the clozapine, while closely monitoring all of the side effects that could occur with clozapine. Simultaneously, the other non-pharmacological management that I would like to start for the patient, in this case, one would be psychoeducation of the family members, because they do not have adequate knowledge about the illness and the concern for the patient though is present. I would like to tell them why this kind of an illness occurs. Considering the significant family history, I would like to stress on that. And as the patient is getting better in the due course of time, I would like to start him on CBT so that I can teach him coping skills to make him deal with to help him deal with certain situations. And I would also like to do insight oriented psychotherapy. And another important factor that I would like to stress upon is the expressed emotions which could occur during the course of illness, which can have a significant impact on the patient's course and prognosis. I would like to focus on that to the patient attenders. And once the patient is better, I would like to introduce him to support groups and encourage him to join vocational rehabilitation so that he can slowly be reintegrated back into the society. Thank you.
Okay, after a very elaborate history by Dr. Sanjana, we will like to start with the Viva. Dr. Sanjana, are you here? Good morning.
Good morning, ma'am.
So I will like you to tell me what is your provision. This is your provisional diagnosis or your confirmed diagnosis?
Ma'am, based on the ICD-10 diagnosis, I would like to consider this as the final diagnosis because he's meeting a few criterias based on ICD-10. Like, for example, the A criteria of schizophrenia, where there is thought alienation phenomena. In his case, thought broadcast that is meeting, and then also he also has somatic passivity, which is another B criteria of schizophrenia, and also the C criteria of hallucinatory voices, which are commending and commanding type. Since that is also meeting, I would like to consider this as the final diagnosis, ma'am.
Okay. Can you give me what will be your diagnosis according to ICD-11 and DSM-5?
Ma'am, according to DSM 5, yes, the criteria that would meet are the hallucinations that he's having, the significant suspiciousness with significant acting out behavior that he's having. Then also there is uh, the socio-occupational impairment that has occurred over the last 3 weeks that can also be considered. And
So your diagnosis will stay as schizophrenia compared according to the duration of illness 1 month as you had told, or it will
yes.
change.
Sorry, ma'am. Yes, ma'am. According to DSM 5, a duration of about 6 months is required to name it as schizophrenia. So, but here it is only 1 month. So, I'll probably like to keep it as schizophrenia form illness.
Okay. Now, in your history, there were certain points that I would like to clear.
Yes, ma'am.
Um, that you had told that the patient has personal judgment intact, yet in last it was mentioned that the insight was 1/6. So can you tell me by like you had told 1/6 insight, right? What do you mean by 1/6?
Ma'am, 1/6 is where the patient does not. Uh, he's not aware of the fact that he has an illness. That is 1/6.
Okay, but you had told in his personal judgment that he wants to get better, he wants to go back home and take care of his family. So do you think they both corroborate with your statement and the insight, final insight that you have given?
Um, for Yes, ma'am. For personal judgment, the reason I said why it can be considered that is intact is because though he does not know that he's got a psychiatric illness and he was brought to the hospital by force of his family members, he still thinks about his family, him wanting to get better, him getting back to his old self. So that is the reason I had considered it as personal judgment as being insight, ma'am.
Okay, but if you're giving 1/6 insight, do keep in mind that what 1/6 means, because in that case, we won't say that personal judgment is intact. But even if he's saying he wants to get better, he's not aware of his illness. Because inside, we are talking in the psychiatric illness, right? So we
Yes,
have to take care about.
sure, ma'am. Yes,
Okay. Okay. Now, in your management, you have not mentioned regarding what mental health section you will be applying for this patient. Can you elaborate on that?
oh, yes, ma'am. For him, MHCA section 89, I think.
Okay, what do you mean by 89? Like, what is the term used for section 89?
um, Supportive admission.
Okay. So, can you tell me the criteria which has to fulfill and how to proceed with section 89?
Ma'am, that is when the patient is not willing for admission himself, but he's brought by a nominated representative. That is a person who is taking responsibility for his treatment, um, taking responsibility of the patient himself, and he's brought in for when he brings the patient against the patient's will. We can admit him, but for a duration of not more than 30 days. Uh,
Okay. What happens after 30 days?
Ma'am, we will have to take information. We'll have to take permission from the review board and also two psychiatrists who, if they are willing to, if they see the need for compulsory IP care, then we can consider prolongation of the admission.
Okay. If the patient is admitted in section 89, as you said, so will you revise the sections or is something, are you aware about that? That you have to revise the sections? How often do you need to do capacity assessment? Do you know about it?
No, ma'am, I'm not aware, ma'am.
All right. Okay. Then you had told me that yeah, there was a somatic passivity phenomenon which you had mentioned.
Yes,
Can you tell me what are the dimensions of a delusion? Like what are the exact dimensions under which we classify delusion?
yes, ma'am. According to Kendler, the dimensions of delusion are one, the effect which is associated, B, if it is bizarre or non bizarre. Delusion, it is considered to be bizarre if it is both impossible as well as implausible. Then C is for conviction, how strongly the person is convicted with the delusion. And then D is for the acting out, then it is acting out behavior. Next is the extension of life into the various aspects of life into which the delusion is extending into. And then the pressure or the preoccupation that the individual has with that particular false thought.
Anything else that you might be missing?
Mm, the the systematization of the delusion, ma'am.
Uh, So the examples that you had given, the verbatim of the patient while giving your what like somatic passivity and other phenomenon, I felt that all the boxes were not checked while giving the entire. When you give a verbatim, a speech sample, like all the components of the dimensions you mentioned right now, they should be checked while giving the sample. Like you had given a brief sample or two, three lines which the patient said, but did you check his conviction about it? That was not mentioned in this.
Okay,
All
ma'am.
the points has to be clearly mentioned. Okay. Now coming that you had mentioned that you'll be using scales for like the scales to check what is the progress of the patient in the treatment. Will you like to use any other scales apart from what you mentioned?
Ma'am, if at all there is he develops EPS, I would like to apply other scales to assess EPS like a abnormal involuntary movement scale or modified Simpson-Angus scale, Barnes akathisia rating scale. Based on the kind of EPS that he may develop, I would like to apply that also, ma'am.
Okay. Now you had mentioned that you will be giving olanzapine 4 to 6 weeks to see the drug response. Let's suppose a patient responds on olanzapine. Then what you will do in the maintenance phase? Will your dosage be the same or it will reduce?
Ma'am, based on the dose that he's responded to currently, I would like to maintain him at that dose for at least a period of another 4 to 6 weeks. And following discharge, I would like to ask him to keep coming for regular follow ups at an interval of 2 weeks to 1 month. And based on that, gradually, I would like to reduce the dose till he's maintained at the minimal effective dosage, ma'am.
And how long will we continue the dose?
Ma'am, since this is his first episode of psychosis, I would like to continue for a period of 1 year, and I would like to still keep calling him for follow ups. If at all there is another relapse of the episode after the period of 1 year, I would like to continue the treatment indefinitely, ma'am.
Okay, now you mentioned me that you will bring him down to the minimum effective dose. I believe that you might be getting confused with certain disorders. Do you reduce the dose in schizophrenia or do you bring the minimum effective dose in other disorders? Are you sure that the dose has to be brought to the minimum effective? What if the patient starts relapsing again? Have you encountered such situations while you reduce the dose to minimum effective?
Like the minimum, I'm sorry ma'am, I meant like the minimum effective dosage for him, like if he's maintaining well without any symptoms or relapse of symptoms with relative premorbid functioning at one particular dose, I would like to keep him at that, ma'am.
Oh, all right. Now, there were certain things that you mentioned in your non-pharmacological management.
Okay, ma'am.
Let's come to psychoeducation. What are the elements of psychoeducation that we'll be using for the patient and his family?
Ma'am, in this case, I would like to first talk to them about why the illness occurs, the genetic loading that it could have, the need for treatment, currently the need for IP care and the need for continued treatment later, the need for important drug compliance and drug adherence. I would like to talk to the family members about that, and also um, other methods of how he can be supported by the family members, like them not showing the negative expressed emotions. All that I would like to talk to the patient's family about, ma'am.
Okay, now since you have mentioned express emotions, can you tell me how you measure express emotions? Is there any scale which is available?
Yes, ma'am. There is this scale, ma'am, called Campbell Family Interview Scale for expressed emotions. I would like to apply that, and also the 5 minute interview scale, family interview scale. Would like to administer that also, ma'am.
And what are the types of expressed emotion that you are aware of?
Ma'am, there are 5 expressed emotions, 3 negative and 2 positive. The negative ones are critical comments, hostility, and over involvement. The positive ones would be warmth and positive remarks.
And which ones are implicated in relapse in schizophrenia? Are you aware?
Yes, ma'am. Mostly it is hostility, it is the over involvement of the patient, and critical comments also, ma'am.
Okay. Now coming that you said that you will be using CBT on the patient. Now, what will be the target of cognitive behavioral therapy in this case?
Ma'am, if at all, because in this case, since I was not able to elicit the presence of any kind of stressor, I would like to speak during serial MSCs. I would like to speak to him and try to understand what kind of a thinking process that he has, to understand why just the install. I mean, if at all he has any certain kind of issues with his uncle, or the reason why he has that particular delusional component towards his own family members. Maybe if he has any interpersonal conflicts with them in the past, if that something of that sort had occurred. So to understand about his thinking process, and later to teach him some coping skills. So that's why, ma'am.
Okay. Any other non-pharmacological management that you will be interested in this particular patient?
Um,
Any other therapies?
I'm not able to think of anything right now, ma'am.
Okay. Are you aware of a term called recovery in schizophrenia?
Yes, ma'am.
Can you briefly describe about it?
Ma'am, recovery is when an individual has attained his pre-morbid functioning for a period of 1 year. Then we call it as recovery.
There are certain components to recovery in schizophrenia. Are you aware of them?
One is, ma'am, him being able to go back to his pre-morbid functioning, and then on objective scales, there is an I mean, on CGI, his score is less than or equal to 3.
Okay, I think you are getting confused with treatment resistance criteria.
Okay.
Anyways, no
Okay.
problem. Okay. Now coming, can you tell me what are the common side effects of olanzapine that you might encounter in this patient?
Yes, ma'am. Most common side effects that we can incur would be excessive sedation. There is weight gain, ma'am, and then there can be orthostatic hypotension. The emergence of metabolic syndrome should be looked into. Um, then EPS can be observed, however, relatively rare compared to first generation. It can still occur, ma'am. Then
Okay.
yes.
Uh, can you tell me that have you taken substance use history in this particular patient?
Yes, ma'am. There is no substance use, ma'am. No tobacco, no alcohol, or other kind of substances as well.
Okay. Had the patient been a smoker or a tobacco consumer, then do you think it will become relevant in your case since you're using olanzapine? Are you aware of any phenomenon related to olanzapine and the smokers?
The When an individual is smoking and taking antipsychotics, ma'am, the metabolism of the drug is faster. So the dose may not be sufficient, and the individual may not respond to the conventional doses.
Is it related to all antipsychotics or it is particular for few of them?
I'm not particular about which ones uh, are the
Oh,
particular.
okay. Okay, we will discuss about it because there is certain enzyme which is inhibited by smoking and it becomes relevant in the case of olanzapine and clozapine. That is the reason I was trying
Okay,
to
ma'am.
ask you. Okay. What if your patient becomes uncooperative and he just refuses to take oral medication? Then how will you proceed with that?
Ma'am, in such conditions, after taking consent from the family, from the attender who's present, we can give him injectable antipsychotic, preferably haloperidol, and starting at a dose of 5 mg, going up to 20 mg per day, along with a coverage of an anticholinergic agent like Finargan, up to, which is promethazine, going up to 50 mg per day, that can be done, ma'am. Or even if with these chemical methods of sedation we're not able to sedate him, we can also do physical restraint for the patient, ma'am.
Will you consider the possibility of long-acting injectable in this particular patient?
Yes, ma'am, we can, ma'am. Especially drugs like zuclopenthixol and zuclopenthixol, flupentixol, since they all have effect on the aggression, they can also be given for him.
Okay. Are you aware of any second-generation long-acting injectables?
Yes, ma'am. There is risperidone, there is paliperidone, aripiprazole, however, not available in India right now. Olanzapine long-acting injectable is also available, ma'am.
Can you tell me the dosage of olanzapine LAI available
Ma'am,
in India?
it is available as 333 mg, 210 mg.
Um, are you aware of any other dosage? There are three dosages which is
450, I think, ma'am.
it's 210, 300, and 405. Okay.
40. Okay, ma'am.
Are you aware of how, like, what is the dosage, how to convert from oral to long-acting dose? Are you aware of that conversion table?
No, ma'am. I have to brush that again.
Okay. Can you tell me heritability in schizophrenia? Like, what are the chances of transmission and how much is the heritability in this particular case?
Yes, ma'am. Ma'am, the lifetime risk for an individual to develop schizophrenia, if at all there are no family history, it is around 1%. But if at all there is one first degree relative, like a sibling or a parent who's affected, the heritability risk is about 10%. In monozygotic twins, it is as high as 45%, and dizygotic twins, it is between 10 to 15%.
Okay. If I ask you what are the bad and the good prognostic factors in your patient, can you describe about it?
Yes, ma'am. Ma'am, in my patient, the good prognostic factors would be the fact that it has occurred at a later age. He's currently 41, so it has occurred after the age of 35, so that is one good prognostic factor. Another good prognostic factor would be that he's married and he's from a rural upbringing. The bad prognostic factor would be his male gender, would be the fact that it is of insidious onset. It would be the fact that there is family history of some psychiatric illness would be another bad prognostic factor, and uh, the absence of significant affective symptoms is also a bad prognostic factor, ma'am.
Okay. What is a normal course of schizophrenia?
Ma'am, schizophrenia, it is usually a long-standing illness which can occur with cognitive deficits. About 10% of them, 30% of them do recover and they maintain well in remission phase. 10% of them, they succumb to long-term bad prognostic factors, and they can also end up with suicidal end up in suicide. And another 30% can have recurring remitting illness, ma'am. And
All right. Now, you had mentioned regarding treatment resistance while in your management that if the patient does not respond, so you will go with the treatment resistance. Are you aware of any criteria for treatment resistant schizophrenia?
yes, ma'am. There is Kane's criteria, ma'am, for treatment resistant schizophrenia. According to Kane's criteria, if an individual has been tried on 3 different drugs belonging to 2 different chemical classes for an adequate duration of 4 to 6 weeks, trying the maximum dosage, which is equivalent to 1000 milligram of chlorpromazine. Despite this, there is no significant improvement. We can consider them as treatment resistant schizophrenia. That is one point. Another thing, ma'am, if at all on BPRS, their score continues to be more than 45 and their CGI score continues to be more than 4, then also it can be one of the features to be considered for it to be considered as treatment resistant schizophrenia according to Kane's criteria.
Okay. Are you aware of anything called modified Kane's criteria?
Yes, ma'am. According to modified Kane criteria, the dosage equivalent of the drug in comparison to chlorpromazine is different, where in plain Keynes criteria it is 1000, whereas in modified it is 400 to 600 mg of chlorpromazine.
Okay. Are you aware of a term called treatment refractory schizophrenia?
Yes, ma'am. Treatment refractory schizophrenia, ma'am, is when the patient has been tried on clozapine also, where a dosage of more than 300 to 900 mg has been tried, and the plasma level has reached up to 350 nanogram per deciliter for a duration of 6 weeks to 6 months, and still there is no significant improvement. It is termed as treatment refractory schizophrenia.
Can you tell me around roughly the percentage of people who do not respond to clozapine?
Around 5%, ma'am.
It is slightly more than that. You have to read about it. Okay.
Okay. Yes.
What are the other drug options we have in case of the patient is treatment refractory schizophrenia or non-respondent to clozapine? What will be your management there?
Along with clozapine, we can augment with other antipsychotics, ma'am. Like for example, risperidone can be tried up to with clozapine. Risperidone can be tried up to 6 mg, or amisulpride can be tried up to 400 to 800 mg. Olanzapine can be tried up to 30 mg. Aripiprazole can be tried up till 40 mg. Then other mood stabilizers which we can use can be lithium or topiramate. Divalproic sodium can also be considered. Then other pharmaceutical agents like thyroxine hormone, the use of omega-3, omega-6 fatty acids, L-carnitine, or even mirtazapine for the negative symptoms that are present at a dose of 30 to 45 mg, and ginkgo biloba are also known to be used as augmenting pharmacological agents along with clozapine for treatment resistant schizophrenia, ma'am.
Okay, and what you will do, the patient is resistant to clozapine also. When the clozapine is not working, you will still augment or will you try other agents?
Other non-pharmacological methods like ECT can be tried, ma'am, or RTMS can also be tried.
What about the pharmacological agents?
Um,
Okay, no issues. Go and
yeah.
read about it.
Yes,
Can
ma'am.
you tell me what is the concept of neurological soft science?
Yes, ma'am. The neurological soft signs are certain subtle features which we see in schizophrenics. For example, the neurological soft signs that we can expect in schizophrenia would be like some features of motor incoordination where they'll not be able to perform the Luria test, or they'll not be able to perform the Ozeretsky's test, or they have difficulty with diadochokinesia or alternating supination pronation. Then some sensory features which they may have is they may have tandem walking, they may have gait disturbances, and they may have other visuospatial disorientation, ma'am, like right to left disorientation. They'll not be able to do stereognosis or graphesthesia, and also the presence of primitive reflexes like the snout reflex, the grasp reflex, the mental sign, the glabular tap. All of these are some of the neurological soft signs, ma'am.
Mhm. Now, coming to some landmark studies, are you aware of any landmark studies in schizophrenia?
Yes, ma'am. The international pilot study of schizophrenia, ma'am, which was done by the World Health Organization, where the one of the Indian centers was Agra, and based on the outcome, based on the conclusion, they said that better outcomes are from developing countries rather than developed countries. Then there is the DOSMED study, which is determinants of outcomes of severe mental illnesses. Then there is the international study of schizophrenia. Then other Indian landmark studies are like the ICMR study, the Madras longitudinal study, the Agra cohort, and the Chandigarh cohort study, ma'am.
Have you heard about AT and Cutlass study?
Yes, ma'am. The KTN Cutlet study also. Yes, ma'am. I forgot that.
Uh, can you briefly describe regarding the PT study?
Yes, ma'am. The KT study was basically to understand the antipsychotic treatment, the cost utility of the antipsychotic treatment that can be used, where they found out that the efficacy of risperidone and olanzapine or amisulpride is useful for the treatment of schizophrenia.
Can you tell me the full form of PT?
Uh, the cost, sorry, ma'am. No, currently it's not coming to me, ma'am. Yes.
No problem. Anyways, it was a very good effort from your side and very well done at your level. There will be certain things which I like to you to improve on something. Okay.
Yes, ma'am.
Like first, while you were giving the speech sample, which I already pointed out, that it has to incorporate all the dimensions of the delusion. It
Okay, ma'am.
cannot be just 2 and 3 lines. It should also include that the conviction the patient has. Okay, it has
Okay.
to be more elaborate. The second thing was that you need to read about the non-pharmacological management there, like the CBT that you mentioned. What is the
Okay.
exact target of CBT in schizophrenia is something that you should be aware of.
Okay, ma'am.
Okay. And then I guess your mental health care act are the sections which has to be applied in the
Okay.
patient has to be brushed up by you because what are the different sections, how it is proceeded, that has to be taken care of. Then recovery in schizophrenia, I assume that you have not gone through that topic because it's itself a very big topic having a lot of components, which is very
Okay.
important for the examination, both for practical and theory purposes. So I will request to go through that.
Yes,
Okay.
ma'am.
Then long-acting injectables was a weak side over here that I could see. So you need to brush up on that as well,
Yeah.
especially the dosage of atypical antipsychotics, how you give them. So that has to be taken care of. Regarding prognosis also, it's not only about the good and the bad prognostic factors, like the prognosis in schizophrenia, like 20-30% have good prognosis, 20-30 moderate, and then 40-60 poor. So that has to be also mentioned in that. And I guess in last, you were stuck on the landmark studies, the PT and Cutlass. So brush up those skills and go through them because they not only ask you the name of the studies, they ask you especially for PT that what are the drugs which were involved, what were the steps. Okay, so you should be aware of.
Yes, ma'am.
That will be the input from my side. And again, it was a very good effort. So congratulations on that. I will like the Dr. Suhas to give certain closing comments upon this case presentation. Sir.
Yeah, so thank you, first of all, to Dr. Sanjana, who presented an excellent case in an examination format. It's not easy to come out in front of your peers and in front of seniors and in front of other teachers and present a case, to be bold enough to do that. But that's the learning, isn't it? That's really the exposure that is going to refine your skills going forward as well. And the entire act of actually going through an examination and a Viva with an unknown examiner, right? So you're going to be habituated to this experience. And so the next time that you're going to do it in your final examination, these things will appear more easily for you. You understand the format, and then you will be able to answer more spontaneously. Most
Yes.
importantly, what I actually want to inform all of the participants today and also the wider TIPPS community is that you can get over the fear of presentation and master this particular art of presentation and examination only by doing it over and over again. Doesn't matter how much theory you know, it is important to actually sort of get fine-tuned and to get experience in presenting the case to multiple examiners as possible. I would like to also thank Dr. Akanksha, who was a wonderful examiner. She covered all the aspects of the basics related to the particular case, and then went into the psychopathology as well, and then went into the important psychopharmacological aspects, augmentation strategies, close-up in, and when do we actually consider close-up in, and then she also kind of wound up with the important landmark studies. This is perhaps how comprehensive the examination process can be, and the examiner can choose to focus on any one of these things. But what I want to highlight at this point of time is that if you have got a solid foundations that are appropriate for in your case presentation, then it is very, very unlikely that you will actually go ahead and fail in the examination. You are going to pass as long as you've got the foundations correct. Now, with respect to the multiple dimensions of discussions that can go on after that, Dr. Akanksha provided a wonderful template for the same. So on this note, I would like to thank Dr. Sanjana and Dr. Akanksha once again. And thank you all of you for joining us today morning and staying with us till about 12:30 in the late afternoon to complete this series of lectures in the case presentation. I once again highlight, if there are other postgraduate students who are interested to present the case, then we are more than likely to accommodate your requests. Please do so by contacting Dr. Gaurav, myself, Dr. Akanksha, or any one of the academic coordinators. You can also post your requests on the TIPPS group. If there are any specific learning needs that you would like us to cover, please also DM any one of us and we will inculcate this. Right? And I would like to thank all the academic coordinators Dr. Swarnabuddha, Dr. Apurva, Dr. Aishwarya, and Dr. Akanksha for today's sessions. Thank you once again. We will continue our discussions in the TIPPS Telegram. All right. Have a nice weekend, and we will see you in the next TIPPS Excel series. Thank you.